Welcome. Today, we will be talking with Dr. Ryan Maves on the topic of addressing vaccine hesitancy. Dr. Maves is a professor of medicine and anesthesiology at the Wake Forest School of Medicine in Winston-Salem, North Carolina, where he serves as a faculty intensivist and infectious disease specialist. In addition to his many other accomplishments, he also served at the Naval Medical Research Unit in Lima, Peru, where he led studies in antimicrobial resistance and vaccine development. And he is the chair of the CHEST COVID-19 Task Force, the incoming chair of the Disaster Response and Global Health Section, and serves on the CHEST Scientific Program Committee. We are very lucky to have him with us today. So thank you so much for joining with us, Dr. Maves.
Oh gosh, Dr. Winter, thank you so much for the invitation. I hear my biography and I wonder who this strange person is that people describe. I'm just happy to be here.
Great. So to get us started, we've all encountered vaccine hesitancy in our careers, but healthcare providers seem to be experiencing a whole new level of it with these COVID-19 vaccines. And many in the healthcare community are extremely frustrated by this reluctance of people to get vaccinated. Why do you think that vaccine hesitancy is so upsetting to healthcare providers, especially in this setting of the current pandemic?
Yeah, why is it upsetting to us? It is uniquely upsetting. You know, I'm a practicing infectious disease doctor, and obviously vaccination is a fairly big part of my practice, and that's much like pulmonologists. We have no small amount of overlap in the patients we see. And you know, vaccine hesitancy has always been with us, but in terms of what's different now, in part of it, it's because the people who are classically vaccine hesitant have changed, right? There was a review, and I need to find the reference for this, but a sociologist looking at what groups were previously not vaccine hesitant. And in 2016, there was some surveys looking at specifically, we'll say, white evangelicals, who are one of the most pro-vaccine groups out there in 2016. And in surveys, were found to be very much in favor of like MMR and varicella vaccines in school, for example, as requirements. And that's changed now. You know, vaccine hesitancy used to be, or to some extent, I mean, to some extent it still is, but used to be a feature we would see in, you know, I grew up in the Pacific Northwest, and we would have clusters, if you will, of sort of politically left-leaning, upper middle class folks who would shy away from vaccination. You can think of them sort of, influenced in part by celebrity culture to some extent. And that's all changed with the pandemic. Some of it, I think, is hardening of existing political lines as a result of the pandemic. Some of it is, I think, some perhaps misguided, but legitimately understandable hesitancy about new scientific innovations. And some of it, I think, is that for some of our people, vaccine hesitancy for COVID has become part of their identity. And that becomes a very hard nut to crack in clinic, where when someone's opposition to COVID prevention measures, be that masking, be that social distancing, be that vaccination, when that gets incorporated into who you are, and you have perhaps some family or social pressure to stay in that group, that's hard for a doctor or other clinicians to crack through. And I'm optimistic that in the long haul we'll do it as some of these tensions dissipate over time, I hope. We can see that in the impacts of some of these vaccine mandates, both from private employers, many health systems. Mine, for example, I assume yours is similar. I don't know that, but I assume. And now, of course, some from state and federal governments, that we are seeing vaccine rates go up or sort of chipping away at this hesitancy. But yeah, this is, I don't want to say it's unique, but it is different. It is a change.
So is there anything that you can tell us about the history of vaccine hesitancy and this anti-vax movement?
Oh, wow. I mean, that is a long discussion, but I think it may make you feel better about this moment in our history if we realize that this is not the first time it happens. You can Google this. You can Google in the Library of Congress. There is a scanned form of George Washington's order for the variolation. Variolation is a predecessor of vaccination, for the variolation against smallpox of the Continental Army during the Revolutionary War. Now, variolation was the thing that came before vaccination. The idea was you would take smallpox lesions from a patient, and then you would use that to kind of do a controlled infection, a controlled inoculation of a person, with the hope you would give them very mild smallpox from which they would recover, and then they would be immune going forward. It was riskier than vaccination, obviously, because you're actually giving people smallpox, but it did reduce risk, and it did control a smallpox outbreak in the Continental Army. But there was this is being recorded for a professional setting, so I'll say there was a huge kerfuffle about this, and not the word I always use when describing this, but these controversies, are the very beginning of the history of immunization, let's say. Probably a lot of the contemporary anti-vax movement circles around a gentleman named Dr. Andrew Wakefield, who was a British gastroenterologist who published data that attempted to link the MMR vaccine to autism. Now that research was subsequently discredited and his license to practice medicine withdrawn by British health authorities. But that kind of laid some of the groundwork for that. And actually, anti-vax tendencies, if you will, pre-COVID were actually even a bigger problem in the UK and Western Europe than they were in the US. Now we're kind of neck and neck, unfortunately. After a slower start than we did to vaccination against COVID in Europe, they picked up and then kind of passed us, although we're pretty close depending on what country you look at. Portugal, for example, basically ran out of adults to vaccinate. They vaccinated everybody. So there are some remarkable accomplishments in Western Europe that we should emulate. But the anti-vax movement in and of itself is not a new thing. It's just more kind of who's in it is different.
And what do you happen to know about Portugal's need for immigrant doctors? No, I'm just kidding.
I've been to Portugal twice. It is a beautiful country. Lisbon is a cool town. I highly recommend visiting it when you can.
I'll add it to the list. So there is obviously a lot of circulating inaccuracies regarding the risks and the efficacy of the COVID-19 vaccine. What do you think has led to this dumpster fire of disinformation?
Yeah, I mean, again, I think it goes back to, necessary caveats apply. I am a practicing physician. I am not much of a student of sociology or of political science, but my impression, and take it for what it's worth, is that, again, some of it is this linkage of resistance to pandemic prevention initiatives with politics and identity. I suspect that's part of it. And when you have that linkage, one selectively cherry picks information to do it. I do think one thing that is different about the pandemic is that, there have always been these debates within the biomedical community, within the scientific community, about the efficacy of a certain intervention, for even when, say, the HPV vaccine against human papillomavirus, which is a great public health triumph and has the potential to eliminate cervical cancer and other HPV-associated malignancies, potentially in our careers, in our lifetimes, if broadly adopted. There were debates about, should we vaccinate all people against it? Is there, should boys be vaccinated? Should only women be vaccinated? Should only young girls, should we wait until sexual activity? Are we encouraging inappropriate sexual activity? What is inappropriate sexual activity, et cetera, about the HPV vaccine? But a lot of those debates took place within us, right? Whereas with COVID, debates about therapeutic efficacy of different interventions are playing out in the press in real time, and our internal discussions are now everywhere, right? You can read to see what this expert or that expert thinks, and while certainly transparency on the whole is a good thing, I think it does have an effect on people who are perhaps less scientifically literate. And that becomes a challenge for public education, not like the public education system per se, but our ability to educate the public, our patients, our neighbors, our families and such. So that's probably part of it. But what we see are, for example, if you remember, this was several months ago, which may as well be like archaeology in COVID times, but about the AstraZeneca vaccine and the Johnson & Johnson vaccine. So these two vaccines are relatively similar in design. They're both replication incompetent adenovirus vectors. The Johnson & Johnson vaccine uses a human adenovirus. The AstraZeneca vaccine uses a chimpanzee adenovirus. But they're pretty similar concepts, right? And then they're each modified to express the coronavirus spike protein. And so there is a risk of pathologic thrombosis in them. The most feared one is, of course, cerebral venous sinus thrombosis. Now, I have seen more cerebral venous sinus thrombosis because of COVID than I have seen due to the COVID vaccine. In fact, I haven't seen any due to either of those vaccines. Admittedly, those vaccines are not particularly widespread in use. In the United States, there's more AstraZeneca use overseas. But so when people read about that risk in the paper, what they see is you get this vaccine and you have a risk of getting a pathologic blood clot in your brain, right? Now, if you look at the actual numbers, the actual risk, the risk of dying in a car accident for a typical resident of the United States every year is 50 times greater than your risk of getting a cerebral venous sinus thrombosis from the AstraZeneca or Johnson & Johnson vaccine, right? Not even dying of it, just getting it, right? Yeah. So, but conveying that risk, people are not necessarily that good at conveying risk and understanding those risks. Not that people understand it, but the risk of dying in a car accident is sort of baked into our background risk profile of living in society, right? Whereas the decision to receive a given vaccine is a conscious decision. It's not necessarily a thing that we've baked into our daily lives. And conveying that sense of risk becomes hard. It becomes hard. And then I think people lose sight of those relative risks, right? Take myocarditis, for example. There is a risk of myocarditis from the mRNA vaccines. I don't know how many cases you've seen. I've seen a handful. When I was in the military, our patient population tends to skew, at least on the active duty side, a little young and largely male, right? Which is the risk group at greatest risk for Pfizer or Moderna-induced myocarditis. This is a relatively mild thing. We actually used to see this all the time with smallpox vaccines in the military. You'd have people would come in with some chest pain, some EKG changes, maybe a troponin leak, maybe not. They'd be in-house for a couple of days, get some NSAIDs, recover, go home. Relatively mild entity. Compare this to myocarditis due to COVID, which is like myocarditis due to flu, right? Where you're talking Impellas and vasopressors, and these people are sick. Well, the risk of getting any myocarditis due to COVID is 16 times greater than the risk of getting any myocarditis due to a vaccine, right? So you got to decide, setting aside issues of severity, are you 16 times more likely to get COVID? Or is your odds of getting COVID 1 in 16 or less? Well, I would posit to you that it's probably quite a bit higher than that, especially if you're unvaccinated. So when people are looking at risk, they see just the risk of myocarditis due to the vaccine, a very rare and relatively mild entity, setting aside the dramatically higher and much more severe risk of myocarditis due to the virus itself. And getting people to figure out that risk profile, it takes time, it takes education, it takes patience, but it's hard. And I admit, I don't know how to build rockets. When a rocket blows up, I think, oh, that's terrible. Someone should have done something about that. But if someone knows how to build rockets, explains to me why things happen, well, then I hope that I would have the wisdom to listen to them.
Excellent point. So let's talk about a couple more components of this vaccine disinformation. What do you tell patients regarding the risks of infertility, erectile dysfunction, risks in pregnancy? I mean, we've all heard about Nicki Minaj's cousin's friend's balls. So how do you address that?
Well, it's funny about the infertility one in men. There was a study, I want to say it was out of Israel, looking at sperm counts in vaccine recipients, and they're actually higher than the control group. So I have somewhat tongue-in-cheek, but somewhat seriously told some of my more vaccine, I'll say on the fence male patients, that if anything, it may improve your fertility, depending on what you want out of life, right? But there is what hard data we have does not reveal it. Similarly, vaccine safety in pregnancy has been extensively covered by CDC, by the European Medicine Agency, by the UK, by Israel, and I think we're all very confident that it is very safe in pregnancy. As far as erectile dysfunction, I'm afraid I don't have any actual hard evidence. My suspicion is that it does not, but I would need to dig a little deeper to address that specific one.
I will say that the data that I'm familiar with is actually that there's a significantly increased risk of erectile dysfunction if you actually get COVID. So
oh, yes, that I absolutely believe. That I absolutely believe. Yeah.
So of course, we all hear from people about these many deaths caused by the COVID-19 vaccine. Yeah. How many deaths have actually been attributed to the COVID-19 vaccines?
You know, I think the answer is extremely few. Norway published a review, a Norwegian public health agency published a review in around May of this year. And they looked specifically at very frail, very elderly nursing home patients with very brief lifespans. And what they identified is they thought they might have found 10 cases where someone's death may have been hastened by vaccination. These are people who were very much at the end of life to begin with. And they make a case in it. I'm not totally sure I agree, but I understand where they're coming from, that, you know, vaccination in general in someone in a palliative care setting may not be the best use of resources, both from a system standpoint and from a patient-centered standpoint. And I certainly understand that. And even someone who is much of a vaccine absolutist as myself, say if you have someone who is on, you know, living their last days in a nursing facility, perhaps foregoing vaccination in that specific individual is not unreasonable, right? But the short answer is extremely few, right? Extremely few. And you know this, and I know this, but it becomes hard to explain it to patients sometimes that, you know, what do we ever do in medicine but shift probabilities? We make an event more likely or less likely. There are very few guarantees of outcome. And when you look at the aggregate shifting of probabilities, how many lives saved versus how much morbidity and, you know, barely touching mortality due to any vaccine, you know, it's overwhelmingly in one direction, right? I have a patient who I've cared for, somewhat kind of funny, in that I cared for her in two different contexts, in two different ICUs, but who is quite convinced that she has an autoimmune disease triggered by one of the mRNA vaccines. She does in fact have that autoimmune disease, and she did receive the mRNA vaccine. She is convinced that the one caused the other. I am not convinced. People get autoimmune diseases. This happens. But figuring out from a broad population standpoint, is there a causal relationship? I don't believe there is. I also know I will never convince this otherwise very kind woman otherwise, right? Whether is that worth my time to convince her? I listen sympathetically and then move on.
The never-ending battle of correlation versus causation. We've all been there.
Exactly.
I also see people discussing the extensive side effects of the vaccines that's thoroughly documented in VAERS. So what do you say about the usefulness of the information in VAERS and how to interpret that information?
Well, VAERS is a passive surveillance system, right? So it only detects things when they are reported. Fortunately, we do have a couple of good methods for getting a handle on the actual rates. One is CDC's VSafe system, which is I think most of us, I'm actually not totally sure if they're still using this, but early in the rollout of the vaccines, you would get a text every few days asking you how you feeling, and then you would report any side effects. And so that was actively reaching out. Now, of course, we also have the data reported on side effects from the phase 3 trials and from after marketing surveillance. I think a skeptic could say that, of course, the drug companies are going to downplay the side effects. That is not my experience. I participated in the AstraZeneca phase 3 trial, and I can tell you that when that got published in the New England Journal, what's published is what we saw. But in terms of what I tell people about the side effects, I mean, you got to be straight up with them, right? I mean, there is a fair chance you're going to feel lousy the next day, possibly even the day after that. But the day after that, you should be fine. And my impression, just from my own practice, is that the shingles vaccine, the current shingles vaccine, the Shingrix, the recombinant one, more reliably lays people flat, for a couple few days after they get it. And when that vaccine came out, people were lining up around the door for it and continue to actively seek it. And I've used that as a discussion point when I've talked to my patients who need COVID vaccination but are afraid of the side effects. I ask them, well, how did the shingles vaccine go for it? And they said, kind of rough the next day, and then I was fine. I'm like, yeah, this is the same. I was lucky. I never had any side effects from any of my 2 doses of Pfizer or my booster, nor did my wife, nor did our daughter. One of my sons had some side effects. I suspect he may have been milking a little bit, but that's fine. But he was enthusiastic to get it, and he was enthusiastic to get his other doses. But we do have to warn people. There was a nurse researcher at UCSF, I believe, who wrote a very nice piece in JAMA Internal Medicine about this. And I'm embarrassed that I'm forgetting her name now that I say it, but it was a wonderful piece where she talked about participating in one of the vaccine trials and one of the early vaccinated people, and said, yeah, I was wiped out. But that's okay, because now I'm protected. And we don't do our patients any services by downplaying those side effects, right? I mean, I reassure them, but I don't say, no, you're going to be fine, and they're not fine. Now we've broken trust. Whereas if I brace people for the fact that, yeah, I mean, don't do it if you have to run a race the next day. But you'll be fine after that.
Completely agree.
And being candid with people about that, it reinforces trust, and it makes them more likely to listen to you in the future.
100%. So many people have also heard that this mRNA technology is too new and it's not well studied. And how do you address that concern?
Oh, yeah. Well, it is new. I mean, they're not wrong about that, but it's not as new as people think. This technology has been in development for many years. It just is that we haven't really needed it up until now. There's 2 kind of streams in COVID vaccine development that came together to produce what we have now. One is that mRNA vaccine technology, and nucleic acid-based vaccine technology, has been in development for many years. I have friends who share a patent on a dengue nucleic acid vaccine, for example. So this technology has been in development for a long time. We just never needed it on this scale. There's a Zika nucleic acid vaccine that probably would have worked. It's just the Zika kind of went away. But that technology has been around for at least a good 20 years. In terms of COVID specifically, the other thing is that when COVID hit, we had not quite 20 years worth of research in developing vaccines against SARS and MERS. And so, which are of course very similar, closely related to COVID, to SARS-CoV-2. And so we weren't starting from zero. There have been mammalian COVID vaccines mammalian coronavirus vaccines in clinical use for many years. Many of them are for animals. There's a thing called feline peritonitis virus, for example, and feline infectious peritonitis, which is caused by a coronavirus. And if you own a cat, there's a pretty good chance your cat has received a coronavirus vaccine as a result. And so all of that technology existed. And it was just a matter of integrating it together, getting it through phase 1, phase 2, phase 3. And then, of course, when you talk about the speed that the vaccines were rolled out, well, unfortunately, during a pandemic, it's very easy to hit phase 3 study endpoints when you have hundreds of thousands of deaths. It's unfortunately very easy to prove that. Whereas with, say, again, harkening back to the HPV vaccine, it takes a decade or so to show any evidence of reduction in rates in, say, cervical dysplasia or cervical cancer. So it is a unique feature. But, the Ebola vaccines that are now, the vaccine that is now available, had a similar a similarly fast rollout because of epidemics in West Africa, epidemics in the Democratic Republic of Congo and such. It is sadly relatively efficient to prove vaccine or disprove vaccine efficacy during a public health emergency.
So even in patients who understand the short-term safety of the COVID vaccines, I sometimes still hear, but they haven't been studied for long enough. We don't know the long-term risks. How do you respond to that?
Well, I mean, they're not wrong. I mean, the people who were the first recipients of COVID vaccines have been vaccinated for less than 2 years, right? The first volunteers in the Moderna phase 1 trial received their vaccines less than 2 years ago. So that's true. What I would say is this, that with other vaccines, the late effects are not new toxicities, but they are waning of immunity, right? That's generally the long-term effects of any vaccine after a certain period of time. Now, one can posit that years or so later, there may be some late complication of the vaccine that we're not aware of. And while it is very difficult to prove a negative, or to disprove a negative rather, what I would say is that this would make the COVID vaccine unlike every other viral vaccine ever. And while I acknowledge that it is a new technology, the human immune system hasn't changed that much. And it can be hard to convince a very reluctant person to accept that. But say if that were the case, that would make COVID vaccines entirely unique. And I don't think they're entirely unique. I think they're great vaccines, but they're not entirely unique.
Well, let's knock out a couple more of these myths out there. Hopefully these are pretty quick yes and no answers. Does the vaccine change your DNA?
No.
Does it make you magnetic?
I hope not. No, it does not.
Is there a microchip?
There is not.
Okay.
I have a, go ahead.
Oh, I was just going to ask, I was wondering if you happen to know the pathogenesis or pathology behind. When I got my second dose, my tail glowed for like 2 days.
It did. My microchip did go on the fritz, but it's one of the newer ones. It's bulky. I actually, we were talking about Twitter earlier. Someone did send me a picture of a tweet that said, in retrospect, inserting the microchips into the horse dewormer was a stroke of genius. I had that on the office, on my door of my office for a little while there because I thought that was funny. I'm not sure all of my colleagues thought it was quite as funny as I did.
I find that very humorous. Now, we're also starting to see more calling the effectiveness of the vaccine into question. So people say, well, I can still get COVID. I can still spread COVID even if I'm vaccinated. So what's the point in getting the vaccine? What do you say to that?
Well, no, I mean, I understand. This again goes to people's ability to assess risk. And it is not, while it is not correct, it's not an invalid question. And I think we do need to answer that. And what I ask people is this, do you wear a seatbelt? And people will say, hopefully, yes. I say, well, seatbelts don't stop you from having car accidents, yet you still wear a seatbelt. This is the same idea. Although unlike seatbelts, this does reduce your risk of getting COVID. So, our goals with any vaccine are, I think, kind of three, right? Our goal is 1, prevent all-cause infection, if we can. Number 2, prevent transmission of the pathogen to high-risk people. And then number 3, reduce the severity of infection if you are infected. And the COVID vaccine very successfully does all 3 of those. Does it do them all perfectly with 100% accuracy? No, it does not. In fact, I think the closest I can think of to a vaccine that has essentially 100% lifelong protection against disease is probably the hepatitis A vaccine, a very difficult trick to replicate. But that is essentially, after 2 doses, lifelong immunity, sterile immunity as far as we can tell. People who get COVID people who are vaccinated and still have a breakthrough case of COVID, though, the duration of their illness is shorter. They shed less virus for a shorter period of time, so their risk of transmission to others is dramatically decreased. And when they do fall ill, they fall less ill. And I'll just anecdotally say I cared for a woman in one of my ICUs recently who's very frail, very elderly woman, end-stage renal disease, intubated. She'd been vaccinated, but obviously a number of immunologic strikes against her, her age, her frailty, her kidney disease. And when I first admitted her, I thought, oof, this is not going to go well. And following the trajectory of so many of our other elderly patients with COVID, and she was extubated 2 to 3 days later, went home, right? A rapid recovery. And while I hesitate to practice by anecdote, to fall guilty of the very thing that I critique in others, but I think it was an interesting illustration. And a large group published a multi-center study recently looking at the effects of vaccination on people who still develop severe COVID requiring hospitalization. And there's pretty clear evidence that even when people get that sick, they get better faster. Their mortality is substantially lower. They're more likely to go home. And so even in those breakthrough cases, the risk is reduced. Is risk eliminated? No. But can we eliminate any risk in medicine? No. All we can do is change the odds. And I think the odds are changed in one very specific way.
Great. So there are some arguing that vaccinations are driving the virus to mutate into a more contagious and deadly version. So what does the science say about vaccines driving mutations in both COVID and other viruses?
Yeah, so the short answer is that is not true. I think part of the argument is that it is applying evolutionary pressure, thinking along the lines of, say, an antibiotic, where you have an antibiotic use in a hospital or an intensive care unit or in the community, and that drives drug resistance. So I think I think that is an analysis by analogy. What we can say is with other comparable viruses, there is no evidence that vaccination is what drives genetic resortment, mutation, development of new strains. Influenza, for example, it's very clear that influenza vaccination is not what drives changes in influenza genetics from year to year. We've had very successful vaccine campaigns, against a variety of diseases over the course of our history. And, measles is a good example. There's no evidence that the measles vaccine leads to the development of new measles strains. Rubella, etc. Varicella, there's no breakthrough varicella mutations that are leading to these problems. And it's not that herpes viruses don't mutate, they do. If you've ever cared for a patient with CMV, you know very well that herpes viruses can mutate and acquire drug resistance. But on the other hand, what does drive mutations? Well, it's a function of the population, right? If you have a large population of circulating viruses with many opportunities to mutate, then that will happen. And I would argue that the reverse of what these people are asserting is rather the truth, that with greater use of vaccination, we reduce the circulating population of SARS-CoV-2 in our world, thus leading to fewer opportunities to mutate. I realize that's a fairly grand argument, but I do think it's consistent with what we understand about how viruses spread.
So let's say you're talking to a patient and you say, have you gotten your COVID vaccine yet? And they say no. How do you open that conversation now so that you can have an honest and productive conversation?
Yeah, I mean, the first reason I ask is, if you don't mind me asking, can you tell me why not? Often the reason is very prosaic. Often the reason is, I was busy and I didn't get around to it. I think that's a thing. That's a statement that any practicing physician can sympathize with very readily, right? I get it. It seems like now's a good time. It's very easy to do so. And heck, while we're here, we can set it up now if you want, right? For some people, they have concerns. They've heard things from friends, they've heard things from family, they've heard things from internet. I ask them what those things are, and then we review them and we talk about them. And I know, and I always know this is going to take time, right? I always know that this is going to affect my clinic schedule on a given day. I do a lot of transplant infectious diseases nowadays, and for our kidney transplant recipients, I really have to encourage them because it affects their suitability for transplantation. And so getting them immunized in a timely manner, it becomes very important, and I feel a little bit of pressure, not from my system or my colleagues, but personal pressure to make sure that I get them properly vaccinated. Some people have beliefs that are very difficult to crack, right? They just flat out refuse. And that becomes, or they have an influential family member, a spouse who's A, not there for me to speak to, and B, is just vociferously opposed to immunization. And that becomes hard to debate a person who isn't there. Most of the time when I've been successful in overcoming these issues of hesitancy, it's because I have established a relationship with this person previously. If I'm seeing someone as a consultant for the first time, it is unlikely that I'm going to crack the code on that in a single visit. I will sometimes have people come and follow up with me later on, people who I might be able to address over the phone, but arrange some manner of follow-up so that we can, A, take the time to establish that relationship. Because I do think this. I do think the one thing that is going to get us over this hump of hesitancy is individual trust, right? It is not going to be public service announcements. It's not going to be celebrities on social media advocating it. It's going to be you, me, our colleagues, individually taking advantage, if you will, of the relationships and the trust we build with people over time. And so I try to find a way to build that trust. I try not to end our visit on the vaccine, right? I try to make sure that we're then, okay, let's talk about something else, something that's maybe higher on your priority list so that we can, A, address your needs, but B, also establish trust. Then we'll come back, and then I'll try again. And we'll come back again, and I'll try again. I do not want to use brute force to get people to see my way. I want to persuade. And I would say I'm batting about 50-50, right? I'm screwing up metaphors. I'm batting about 500 on that.
Great batting average.
Thank you. It's okay. It's not bad. But it does take time and it does take patience, and there isn't a recipe. But I have had a lot of people who I've been able to convince over time of the safety, but that required building credibility with them. I will say people do surprise you on occasion. I saw one patient in consult who had not been vaccinated, very much needed to be vaccinated, and was whose spouse was very much opposed to vaccination. The spouse wasn't there, but this patient was accompanied by an older woman from her church, and I practice in North Carolina, and I was not sure what direction this was going to go. And the person from her church who was accompanying her, when I recommended vaccination, said, yeah, our pastor talked about this and very much wants all of us to get vaccinated. And I'm like, yes, listen to her. You like her, you know her, listen to her, very wise. But people surprise you, right? And that was, I think, a valuable lesson for me to not have preconceived judgments about how different groups are going to respond. And that patient, thankfully, was ultimately vaccinated and did well. And maybe that's the lesson, right? It's individual victories, that each one person who we persuade to get vaccinated, that's one fewer person who's at risk. That's one fewer person who's going to get COVID. That's one fewer person who's going to transmit COVID. And that's maybe the thing that gets us through our days, right? Is knowing that those individual victories, eventually they add up.
Well, that seems like a great place to close this conversation. So what closing thoughts do you have for our audience that you want them to take away from this discussion?
Oh, gosh. Well, this is for the Critical Care Network, of course. And I think for a lot of us, we've grown, we're getting tired, right? We've grown perhaps a little more weary, perhaps a little more jaded in the last year and a half, 2 years. And I realize there are a lot of experts on wellness and physician resilience and the like who have discussed this more, how should I put it, more eloquently than I ever could. But one thing that I have found useful in my own work was something that a colleague said, that to remind myself that the unvaccinated, often willfully unvaccinated patient whom I'm seeing in the emergency department, in my ICU, about to put on high flow, about to intubate, is in many ways the final victim of a campaign of misinformation. And I find that is a useful way to at least help me restore my empathy. And similarly, when I see patients in clinic who are in that same position, not in the about to be intubated position, obviously, but who are coming from that same angle, to remind myself that I'm not trying to just convince someone. I am trying to undo an injustice, and an injustice inflicted upon these people. And I hope that I succeed more often than I fail, but even one success is a success.
I love it. Well, I'd like to thank Dr. Maves for sharing his expertise and passion and time with us today. And a big thank you to all of you healthcare providers out there listening to this and working to save as many lives as possible with vaccination. Thanks for joining us.
Thank you so much for having me.